Hello again. So it was very interesting being asked to do this because there's a lot currently of the work that we're doing in Liverpool, research-wise, both basic science and clinically, in the ligamentous aspects of the ankle fracture. So I do have disclosures on this because I'm an implant designer for Ortho Solutions and a consultant based on some ankle stuff for Stryker and Johnson & Johnson. There's a lot of work on ankle fractures on the YouTube channel. So if people want to learn more about this, I guess Posterior is very evident within that. So on our Liverpool Foot and Ankle YouTube channel. So first of all, definition of instability. Now, Xavier is not here. I would refer to him on this one because when the FAME trial was initially being designed, it went round with what is the definition of ankle instability. And the definition to a foot and ankle surgeon was very different to a definition for a trauma surgeon, which was very different to definition across the different specialties, really. But this is the starting point, okay? The ankle joint itself is displaced or can be displaced if subjected to normal forces. So if you put a normal force through their ankle, be it what is a normal force, then you lose its congruency, okay? This is talked about in AO where you have the ring, and if you lose two aspects of that ring, then you lose stability. There's a little bit more to it than that. So the concept of ring injuries was developed further by this group this year. Retrospectively, study of 277 ankle fractures, 4 different types of fibular fracture were differentiated, and they found that they had 96% accuracy rate if they used this. Based on this, we're going back to the Lauk-Hansen classification of SCR, PER, SAD. But as you can see here, it's not just the bones. So we have the AITFL, PITFL, ATFL, your interosseous ligament, PITFL, again AITFL, and your deltoid on your medial ligamentous injury. Goes further than that. So this is the case I had a few years ago, where we had a small fracture of the anterior lip and also the lateral ligaments had gone. And if you get your ankle to destabilize this much anteriorly, it's your AITFL really, that's the thing that's damaged. And through stability, through one screw to fix the small fragment anteriorly and repair of the deltoid, repair of the lateral ligament through a normal rostrum, we can obtain stability. So it can be a bit more than that. This is a paper that we published almost 2 years ago now on ankle stability in ankle fracture. And you can see here that if we talk about the different planes of the ankle movement, be it sagittal plane, translation, sagittal plane rotation, you have a lot of stabilizers which are ligamentous, not only bony. Similarly, frontal plane, we have y-axis and x-axis rotation. You can see CFL, PTFL, ATFL, and a lot more then on the lateral aspect. Horizontal plane or Z plane rotation, again, you have a lot of ligaments that are involved. So if these are providing stability, and as we said earlier, what we want to achieve is an ankle fracture fixation that allows them to weight bear right at the start, then you might need to do a bit more than just repair the bones. Okay, so first of all, the medial ligaments. So medial ligaments is not just the deltoid. The deltoid, the deep deltoid, which controls the talus, is a very small part here, that number 4. But the rest of it is your combination of your tibia calcaneal ligament and your spring ligament. And all them provide is your hindfoot stability. It's not just your talus stability. I'll go into that a bit more. And really, this was a light bulb moment for me about 3.5 years ago. And I discussed this with my colleague, Alan Pillai, who works in Manchester, in Belfast this year. And he did give me this. He just started stamping the floor going, oh my word, why didn't I think of this? Okay. This is becoming a bit of a light bulb moment of that this deltoid injury is not just deltoid, but also a spring ligament. Okay. These are the ones that we are now very concerned with, because what they come back to clinic with is flat feet. So you do a ankle fracture fixation, you weight bear them early in the boot, all hanky-dory, by the sort of discharge and physio at 6 weeks, yeah? But their feet are flat. Okay? One important ligament is this deep posterior deltoid, and the reason for that is that this is what gives you stability in regards to your talus. So deltoid instability, okay? So for those who are junior in the room, the Ramsey-Hamilton paper, 42% displacement. If you go a 1 millimeter displacement, you get 42% decrease in contact area. Very classical paper. It was actually repeated by the Newport group and found exactly the same thing. And this is your contact area in normal, and then you move, and therefore there's a higher chance of getting arthritis because the ankle's not contacting the two surfaces correctly. So I will push on about the definition. Number one, definition of ankle instability by undergoing treatment. Because what you do with these patients is that we put them in plasters, we put them in boots, we put them in, we sometimes fix them, okay? So if you can maintain the tailor centralized, when it's in the neutral position, then isn't that stable? Because that's what you're going to do with them. So how do we know that? Stability tests. So there's a few stability tests. Manual stress test is, it should really be done under anesthetic, otherwise patients hit you. The gravity stress test, the problem with that is the poor standardization because your equinus position will dictate what will happen in your medial clear space. And then you go weight-bearing radiograph. Two papers from the Guildford group showed that the gravity stress test had a 45% chance of unstable. But weight-bearing radiographs, within 2 weeks of injury, went down to 3%. So this is a difference in operating by 42%. So in our unit and around the country, weight-bearing radiographs, and this on the BOST guidelines, should be done within the first 2 weeks, and that then dictates your stability. So giving you an example of this, so this is a young lad who had an ankle injury, doesn't look that bad. He's got an obvious fibular fracture here, doesn't look that bad in non-weight-bearing. Weight-bearing views, he's got opening up the syndesmosis and the medial clear space. He's had a routine ankle fracture fixation with plates and screws, on a tight rope, and a deltoid repair. This patient, actually this looks a lot worse than the last one, doesn't it? Okay, non-weight-bearing view. In plaster doesn't look too bad. Weight-bearing views, normal mortise, stable ankle. So this patient goes in a boot, gets him walking. I'll see him back in 6 weeks, get him to physio. Okay. There's a randomized controlled trial on that, BMJ open, walking boot versus ORIF. For those who had stable ankles, no difference in functional results. And this is what we do throughout now. So do we repair the deltoid ligament? So if we do have an unstable ankle, do we repair it? Okay, so I grew up on a concept that we never repair deltoids because there was no difference. We just don't do it. Okay, so biomechanical studies. So Nish Kadakia was in Michigan, one of my mates, so he's done quite a lot on this. So after deltoid repair, talar coronal and axial rotation normalized. So this is an intact ankle, it's an injury state. And then if you just fix the lateral side, don't fix the deltoid, you've still got not only your instability at your talus, but also the hindfoot. Look how far this swings. That's because your sustentaculum attaches to your medial malleolus. And with the deltoid repaired, we got stability. This is from Mark Easley's group in America. So intact, both disrupted, syndesmosis fixed, yeah? So you can see with those who both repaired, we are achieving normality in anterior draw, posterior draw, medial draw, lateral draw, which you don't with the others. Okay, the only thing that you don't really achieve is on your external rotation, but everything else you achieve if you repair both the deltoid and syndesmosis. Okay, there's now a difference. Do we do it for deep or superficial? And this is the next bit of controversy. Personally, I think there's the superficial we need to repair, but this biomechanical results showed no difference for your deep and superficial, so they contributed similarly in the dysfunction on the medial aspect of the ankle. And this is the next bit. So this is a paper on, okay, well, do they cause flat feet? So TMT instability score and lateral translation score, both of them very, very, very significant for those compared to those who were injured without the deltoid being repaired, and those and the other contralateral limb showed that they had flat feet if the superficial deltoid hadn't been repaired. Okay, so give you an example of this. So this lad actually turned up to clinic, been walking on this ankle for 2-3 weeks, and he's obviously got a fracture of the fibula and this medial opening, yeah? So we've fixed the lateral side, very routine, and stressed it. We got opening up the syndesmosis and opening up at the deltoid, yeah? Okay? Then we fix the syndesmosis, and we stress it again. Now, the talus doesn't open up that much. Can you see how far this swings? Okay, this is called now, I term a hindfoot stability test. How far does calcaneus swing, and does it hit this lateral fibular line? You can see it doesn't here, and then it does when it swings, okay? So if you're going to get this patient weight bearing early, then they're going to flatten. So simple repair of superficial deltoid, then retest, and you see it doesn't swing. Another case, very similar. Again, you can see that this swings without repair, and then it doesn't swing with repair. So clinical results, there's a meta-analysis of deltoid repairs. 1,000 patients included, a total of 8 comparative studies, only 2 RCTs, so not very high evidence. However, medial clear space was significantly superior in the deltoid ligament repair. Ankle, AFS ankle score was significantly improved. No difference in pain score. Complications was also significantly improved in your deltoid repair. So both clinically and biomechanically, it makes sense to repair your deltoid. Okay, so syndesmosis. So first of all, and I don't mean teachers suck eggs, but we got the front ligaments, the front, middle, and back. Yeah. Okay, and your TFL at the front is usually in 3 bands. This one, we've done a bit of anatomy work on this. Often your band 3 does go into your ATFL. At the back, you have your deep PITFL. And we go to the superficial bit now. There's another bit of our anatomy work, but also got this intermalleolar ligament, which is a secondary stabilizer. When you're scoping ankles from the front, often you can see this overhang in the back of the ankle as a secondary stabilizer. What we found that when we done our posterior malleolar work, people were saying, well, why aren't they all unstable if they've got a posterior malleolar fracture, if that's where it inserts your deep deltoid? But it's because you've got this very, very large superficial deltoid component as well. Biomechanics-wise, so first of all, your fibula rotates. So your fibula not only posterior translates a very small amount, and then it pivots on that posterior malleolar. Okay? So the fibula's main movement is external rotation with some posterior translation. So it moves backwards and externally rotates. So for syndesmotic stability, your AITFL is the most important stabilizer for rotation. That's the first thing. All ligaments need to be damaged to rock and roll instability. So I grew up with the hook test, absolutely rubbish test. You have to have all 3 ligaments gone for it to be positive. When your external rotation test will tell you if your AITFL is gone. Okay, and then the sagittal plane motion is significantly greater than the coronal plane. So if you've got these unstable fractures, take them to theatre, hold the fibula, move it back and forth. Okay, it moves loads. So when you've got instability, it's the sagittal stability that moves the most. And that's dependent on, your posterior malleolar, and the smaller posterior malleolar chunk you have, actually, the more it resists this posterior translation, weirdly. Okay, posterior malleolar fractures and syndesmosis. So I had to add in a bit of it. So there's now 6 papers rather than 5, indicating a reduced need for syndesmotic stability. However, and this is the caveat, because I've had this even in my own unit, some PM fractures don't have syndesmotic instability, okay? This is our paper back in 2017, showing that with the larger fractures, the larger the fracture, the less ligamentous injury you get. It's counterintuitive, but I'll show you on the Wagstaff, it's the same. So this is our paper, again, with this large area of superficial deltoid. So even with the larger fractures, the ligaments don't seem to go with it. Okay, that's the comparison, showing that the superficial deltoid is much bigger than the average fracture. So some PM have persistent instability even following PM fixation. So there's some papers now saying, okay, we'll just fix the back and the syndesmosis is stable. It is not. That's not the case. And the reason for that, so this is, you can see, very wide space between the syndesmosis, okay? It's got a type 1 fracture, so if this is a PITFL avulsion, you can still see the gap. They had a fixation of the posterior malleolus, but have left because they felt that at that stage they'd fixed it and therefore it is stable. But you can still see it's not. And the reason for that is because you still got an injury to the other ligaments in this syndesmosis. Okay, these ligaments are still damaged. Okay, There's a good paper done on this this year, looking at Mason nerve injuries, so injuries of high fibular fractures with a posterior malleolar fracture, done in the CAD labs, and actually you can see that the intact, you still had, even if you just fixed the back, you still had this instability unless you fix the syndesmosis. Okay, and even further, the intermalleolar ligament can be avulsed as well as a secondary stabilizer. Wagstaff fragments is the front bit, so this is the bit that's involved with the AITFL insertion. So this is one of our papers, and we looked at, number one, the Wagstaff length. So if this is big, does that mean that it's unstable? No, that wasn't true. Okay, and the reason for that is that your average AITFL footprint is a lot lower than the average Wagstaff fragment. So often you can still have a stable syndesmosis even with a large fracture because it doesn't take out all the ligaments. Interoperative wise, so as I said, hook test is very low sensitivity, so external rotation test, because that picks up AITFL. Okay. Also look at the posterior aspect if you've got a PM fracture, for example, an internal rotation test. So this is someone who's had a small posterior malleolar fracture with a PITFL insertion, and you can see that it's opening up. And with the screw, it doesn't anymore. This is a case of mine 2 weeks ago. It's an undisplaced posterior malleolar fracture. You can see a TLO type fragment that does attach to your AITFL and a fibula fracture. So I fixed the fibula and I fixed this small TLO fragment. But with that, when I do internal rotation tests, you still open up. So again, the screw's been placed to prevent that. Assessment-wise, you can feel over the top of it. You've got to know what you're feeling for. Or you can actually open it up and see it. If you open up and see it, you look for this Mercedes-Benz sign. All right? But you can often feel it. And there's no significant difference between the two as long as you learn how to do the palpation. And this is what you're looking for if you're looking directly. Look for this corner and this AITFL and ATFL tubercle to sit underneath the anterior aspect of the incisura. Next part is on your coronal instability, where does the fibula sit? So a lot of registrars have found this a bit strange. I get a lateral before I fix the syndesmosis to make sure the fibula is sitting where it is, and then feel the reduction. And if it doesn't correspond with interacting with this corner, then just think it may be not in the right position. Okay. So clamp-wise, predictable clamp placement between the anterior tibia. So what you want is this bit here. This is the predictable bit to get your right reduction, and that's where you want it. And also, where you know that spike is then, that's where you aim for your screw or tightrope if you're placing it. You can influence it with the clamp. So if there's any slope, anterior or posterior, it can slip out one way or the other. Posterior malleolar fracture similar, it can slip out the back. This is an example from one of our cases published in FAI many years ago. You see this over-squeezed syndesmosis looking like, and this fragment is off. That has to be a mal-reduced posterior malleolar fracture syndesmosis. Okay, and the reason for that, going to play? Nope, sorry, is that they've squeezed it, it's gone out the back, and then you can see with this fixation. So this should be sitting here. So it's just one of the things to note. Where do you place it? So the syndesmotic recess is 1 to 1.5 centimeters from the joint, and then your greatest strength is about 2 centimeters from the joint. And then above that, then you've got the perineal artery perforator that comes from the perineal artery into the front of the ankle. And what you don't want to do is catch that with one of your screws, and that occurs 3.5 to 4 centimeters above the joint. So in theory, you want it between 1 and 3 centimeters of the joint is where you want your screws. Hardware choice, well, so level 1 meta-analysis RCTs on this one, simple ankle fractures, but between a tightrope and a screw, it does favour throughout functional scores and clinically relevant complications using a tightrope. Okay, throughout all of them, and also this one in BJJ this year showed that syndesmotic stability for the screw compared to using the dynamic fixation, so a tightrope showed better for the tightrope. The problem with that is, when do you use it? So number one, is the fibular length and rotation restored? If it's not, then don't depend on a tightrope, because it just drifts up approximately. Some people still do, but I've seen some disasters with that. If the fibular length is axially stable, if it's not, so if you fix the fibula to length, then yeah, fair enough, you're just controlling rotation. And that's what the tightrope does. Otherwise, use screws. Is the position of the fibula and the institute confirmed? If not, then position it there. Then you can use either. Okay, so the typical example here, there's a major nerve fracture, posterior malleolus fracture. So by bringing this down in the right position, you're going to get length. Okay, and then all you're doing is correcting rotation. So as you see, one screw at the back, and we've got this to control rotation. Very simple fixation, but it works very well. Ankle position on implant insertion, it doesn't matter. So I was taught that don't push it up because it opens the syndesmosis too much. Or if you don't have it in the too far up, then you squeeze it too much. There's 2 studies showing there's no difference. Lateral ligaments. Okay, there's not much in lateral ligaments on this. Okay, beautiful paper from Barcelona showing the anatomy. So this is your lateral ligament complex. Weirdly, it comes together. So your ATFL and CFL comes as one area and sits in the same spot. So if you're going to do a repair and you put your anchor here, you can catch both bits. All right. Weirdly, your PTFL actually also connects to your ATFL. It connects internally. You see this? This was news to me when I started dissecting these out. Beautiful, beautiful dissection here, showing ATFL and PTFL is actually still almost the same ligament. So ATFL absence and the issue with syndesmotic repair sometimes. So weirdly, I've had 3 cases. Hang on, coming up to this talk, which is good. I'll show you 2 of them. Okay, so this case, a large posteromalleolar fracture, major nerve type injury, medial fracture. This is what it looked like. So for this, I'd usually be planning to do a medial posteromedial incision to get to both these bits, and I can get to the front to the same incision and then a lateral incision. That's what I've done. I've controlled the posterior malleolus fracture, yeah. But then when I've put these screws in, because it's a major nerve, we're not going up the top end to fix the proximal fracture. I put these screws in, the talus is pushed forwards. It's like a bar of soap. So you squeeze it, and once it's done, it's just popped out the front. And the only reason it can pop out the front is if the ATFL is not present. All right. So I've got 2 options on that. I either take the screw out, which I have done, and the talus is now sitting back to where it should, or I repair the ATFL. I actually didn't repair the ATFL on this one. Okay, this is another fracture. This was done by one of our fellows. So quite a nasty injury, almost log split up to the syndesmosis. He did a really good job on the AP, yeah. So fibula is nice out to length. He's got a good syndesmotic fixation, beautiful fixation on the medial side, but the talus is popped out the front. This is weirdly with the syndesmotic fixation with a tightrope, because you don't think you can over-tighten that really. Okay, this was him a few weeks later. I came to my clinic, and obviously we needed to do something more on this. So I took him back to theatre a few weeks ago. Unfortunately, all the anterior aspect of the cartilage had also been damaged, and I've done an internal brace to bring the talus back into the right position. Okay, ATFL intact and fibula short. See that this fibula is in a lot of pieces. It's quite difficult to get the length in the right position, I find it is. So I've done bridge painted this. I've fixed some of the other fragments back. I have done a deltoid repair as well. But even in this, you can see it's quite a little bit narrow in here compared to this side. And also, the ring sign is broken. So this is not that far down, not as far down as I'd want it to, okay? All right, then he comes back to clinic and get weight-bearing views, and he's fallen into this area. And the reason he's fallen into that area is not because he's got a joint injury, which can occur. It's actually because the fibula is short. All right? So this is some cadaveric work we do in the last few months. So this cadaver's been skeletalized, cut the ligaments, and then we shorten in the bone. And in doing so, as soon as this ATFL hits this anterior aspect of the insula, what happens is that this is bigger than this area. So the only way you can go is lateral. So the reason why this is going lateral on that last x-ray is because the fibula is short and this bit is hitting this bit. Okay, this is, we show that sort of that up to 5 mil shortening is okay, but as soon as you get past that area, it interacts and you get this jump. And this is your medial clearance is getting bigger and bigger and bigger as the fibula shortens. To get back to this case, if you have a look at the CT scan, this area should be sitting down here. Okay, so this is about 5-6 mil of shortening. This area should be down here. And the reason why it's up there is because it's short. So I've taken him to theatre, I've done scarf osteotomy of the fibula, I used the compression distraction device, jacked him up to length, and got the medial side back into the right place. He's now 2.5 years down the line. This was him intra-op. He also had a flat foot, so I've done a calculating osteotomy. This was him, as I said, I saw him 2 months ago. He's about 2.5 years down the line. He's back to complete normal function. He's still a bit flat, but his medial clear space is back, and that's because the fibula's out to length. So as a summary, so I'll use a case as summary just to bring all this back in. Okay, so a major nerve injury, open medial clear space, as you can see. We got a posterior malleolus fracture. This is what it looked like on CT scan. So I'm fixing the back, but as you can see, I'm starting fixing the back. So this is upside down at the moment. Okay, can you see how much widening we have here? Okay, and that's the reason because the syndesmosis, fibula short, syndesmosis open. That's how much widening we got. So to prevent that, I put a clamp on syndesmosis to reduce that, and that has actually brought down your osteomalleolar fracture. And this is what it looks like now when I'm fixing the back. All right. I put a syndesmotic screw in. It is a bit bent, okay, so unfortunately, but it's in such good position I didn't want to change it. And in doing that, I repaired the medial deltoid because we know that was unstable. And the reason for that is when I actually stressed it, you can see that it's got high instability, even with the construct of the ankle being okay. And that's where I end. I hope that was informative.